Hello, everyone. My name is Melissa Knox, and I am an ambassador with the United Mitochondrial Disease Foundation. And I am going to talk to you today about obtaining educational accommodations for children with mitochondrial disease. As you can guess, this is a very complex area. I'm going to cover everything from evaluation to the creation of an IEP. If you have more specific questions, you can always contact Margaret Moore, our support associate, and get in contact with an ambassador in your area. So like I said, my name is Melissa Knox. I am a mother of a son with knee loss, and I have been an educational advocate for children with autism in South Carolina for close to 15 years. I also currently am a CDC school disease intervention specialist. That means that I work in the school environment in cases of public health crisis, such as the COVID pandemic. I have a graduate education from Baylor University, and my grad project was with the UMDF, which is actually part of it we're watching right now. So the need for educational accommodations is something I want to cover with you first, because this is a very important concept. Usually when we think of education, we think of equality, which is that image on the left. Equality, as we know, isn't equal for everyone. Equality allows for everyone to have the exact same service instead of having this individualized supports what they need. So when you talk about educational accommodations, especially when you're talking to a school corporation, we really need to focus on this concept of equity. Because education is an area that is different from all other federally mandated areas. Equity must be present in the classroom to allow for each child to receive a free and appropriate public education, or FAPE, which I will talk to you more about. So your child already has or is pursuing a disease of mitochondrial disease, but there are two different types of diagnosis. There's a medical diagnosis that's determined by a licensed medical provider. It's probably your geneticist, maybe your neurologist. And then there's an educational diagnosis. And an educational diagnosis is determined by the school system through the evaluation process. And if you do not have this diagnosis, you cannot receive special education services. But just remember that that medical diagnosis alone is not enough to receive educational accommodations under the Individuals with Disability Education Act. So these are some areas that your student might be eligible for accommodations in the school environment. So that's an IDEA, is what I'll call it, that, or IDEA, which is the Individuals with Disabilities Education Act. That is the first area that most people are going to be eligible. And then second, if they're not eligible for IDEA, there's Section 504 of the Rehabilitation Act of 1973. If your child does not meet criteria under IDEA, they will definitely meet criteria under this. There's also individualized health plans and state-specific rules and regulations. In addition to this, we will also show in another video where there'll be a link for state-specific regulations. Everything that I talk about today will be under this federal law, but states have specific rules. There will be an area that you can access your state-specific rules, which may give your child more benefit than the federal law. So child find. If your child is symptomatic early on, they will be eligible for benefits at the age of 3 under Child Find. And Child Find is the affirmative ongoing obligation of states and local school districts to identify, locate, and evaluate all children with disabilities residing within the jurisdiction who either have or suspected of having disabilities and need special education as a result of those disabilities. As you can see in this statement, even if we suspect mito and your child has a large amount of symptoms, they can be eligible under Child Find. So what this must include is children that are advancing from grade to grade, even at a regular level. So if we have a child that's advancing in grade, So some children, they'll say, let's keep them back in kindergarten for the second year. We'll usually say okay to that because, children take longer to mature. So if they're able to advance to first grade after being held back that second time, it does not mean that they are not eligible for evaluation under IDEA. And this also applies to highly mobile children, including migrant children in this child find process. So if you have, or military children a lot of times may be eligible under child find for evaluation. So to be eligible for services under IDEA, there's a two-part test of eligibility. So the first question, does the child meet the criteria for one or more disability categories under IDEA? And we'll talk a little bit about those categories in another slide. If the child does not meet those criteria, but has a medical issue that affects their education, they can still be eligible under Section 504. But if you can answer question 1 in the affirmative, then we move on to question 2. So if so, does the student need special education services? So this really means, does the child's disability have an adverse effect on their educational performance? So after we determine that a child may be eligible for special ed services, we really get into this evaluation piece. And this is going to be very important, especially with mitochondrial disease when we're talking about a super complex level of need. So a request for the determination of an eligibility for a student to receive services under IDEA or Section 504 can be made at any time by a parent, caregiver, or a local agency representative. And we are going to call those representatives an LEA. And when you make this request, all parent caregiver requests should be in writing. And this is important because once you request an evaluation, a school district has 60 days to complete that process. If we don't make a request in writing, there's a chance that your child could slip through the cracks. So that's super important that you make all of your requests in writing. And remember, proper evaluation is the foundation for all educational accommodations. So to even begin an evaluation process, the school districts have to obtain informed consent. And what this informed consent is going to be, it's going to be forms for physical therapy evaluations, speech evaluations, anything that you feel like your child is struggling with, they can evaluate. So they're going to provide you with a copy of their procedural safeguards. And this is going to go back to that state supporting law. It's very important to review your safeguards. In some states, your child will have more affirmative rights to have the process completed in a specific amount of time, be eligible for a secondary evaluation, which we'll discuss in a little bit. And it tells you who you cannot include in the process. But in order to do an evaluation, they must obtain parental and treating physician input. So this means that this is your opportunity to tell the story of your child. And then your doctor's opportunity to talk to them about mitochondrial disease, which they probably won't know anything about. So we really need to make sure, since this is our foundation, that we're sharing everything that we can. And like I said, they need to conduct that evaluation within 60 educational days of receiving the signed consent. And you need to really monitor the clock. What I always recommend to my advocacy clients is that we just set a Google Calendar alert so that we're sure that the process is proceeding as it should. So when we talk about the things you need to consider for evaluation when you have mito, we're going to look at that full medical day needs of your child. So pretty much from The time your child wakes up in the morning to the time they go to bed, what do they need? And some people say, well, they don't need that during the school day. The whole point of giving them all of the information is that at any time, your medical status can change. We all know that. Things can happen the drop of the hat. Something that's never happened at school before can happen in that environment, and we really want them to be prepared. And considering the complexity of many of our children, the more information they have, the better they are able to make good, accurate decisions. So what we want to consider are, when are your medications delivered and how are they delivered? So communication deficits. Communication deficits can be anything from, for a kindergartner, not being able to form any letters is considered a communication deficit. So your speech, your use of alternative communication, vision and hearing deficits. My son personally, he has sensory neural hearing loss. So one of the first things that we addressed was his hearing in the classroom. So nutritional issues, aspiration potential. Do they need thickened foods? Do they get adequate nutrition? Do they need dietary support? What about mobility issues? Do we have any fall? Are they at fall risk? Do we have the need to have someone help them, move from their chair to a bed or to toilet? GI issues, including that cyclical vomiting, constipation, for example. And child-specific effects of physiological stressors. Those are environmental factors, which I'll discuss a little bit later. Pain is a big area that needs a lot of consideration because pain affects everything. We all know that children can be dramatic. With my son, sometimes when he was younger, it was just the simple things. And then his headaches always seemed bigger to him. But his pain was affecting his reading comprehension, is what we found out later. Had we not looked at the pain, we wouldn't know that. So we always want to consider that. How you feel in your body affects everything about your education. So what symptoms do you require tracking? Do you track blood pressure, blood sugar? It can be weight for some children. And these are all things that can need to be considered. Infection susceptibility, or the need for frequent absences. As we all know, after all these years with COVID, illness happens and our children are more susceptible. So what do we need to do to protect them during a time of a high COVID rate or influenza outbreak? Are they going to get every single cold that goes around, every single stomach bug? Under the laws of most states, children are only allowed to miss 7 to 10 days of school without the parent potentially having interaction with child services. So we need to state this up front and in writing, just as a way to protect yourself and your student. And of course, there's lots of fatigue considerations and its child-specific effects. Does this mean that your particular student can walk by themselves in the morning and can't in the afternoon? Do we need to make accommodations to allow them to sleep, which we'll talk about a little bit more later? And then there's also special evaluation considerations. And these are going to be some things that you're going to have to do and really monitor more. So you should obtain a letter from your treating mito physician that describes a diagnosis and prognosis for the child. Some of you may not have a prognosis, they may not be sure of the outcome, but as long as it's in writing, you're going to be okay. And this evaluation process must be continual. Just because we look at the child once doesn't mean we're done. My son entered special education at the age of 3 and he exited at the age of 19 when he graduated high school. During that time, he had 17 evaluations. This is normal because as their condition changes, we want to make sure that you're getting the utmost assistance for your child that you can. We want to make sure that the process is going seamlessly when you're going into the IEP. And this is very important. No single testing method can be used as a sole criterion of eligibility. So this means that a school district cannot tell you, we did this battery for a behavioral issue and he didn't score high on it. Well, then what about another battery? We need to evaluate more than one method. So an evaluation must assess all areas of need, not assume a certain level of disability, assess functional, academic, medical, and developmental information, including information provided by the parents and treating clinicians, and be complete enough to gather all relevant information to develop a qualifying students program. I had a client here in South Carolina who had an evaluation where they did not consider the physician's input, and the child had a hypoxic brain injury. Because they did not consider all relevant information, the state of South Carolina now prays for a private school. But that was because we went back and recorded that they did not accept this physician's input into this process. So what they must do is very important for you to consider. If you do not agree with an evaluation, you are eligible for an independent educational evaluation, or you'll hear it called an IEE. And an independent educational evaluation is conducted by an examiner that is not part of nor conducts contract work as part of a school district. This is someone that has no financial incentives whatsoever. IEE is very expensive, so it is reserved for when a school district fails to conduct a complete evaluation, such as it does not look at that physician input, parents do not agree with the district results, or a failure of the IEP to address the needs of the student. Parents who do not agree with the school's evaluation can ask the school to pay or request reimbursement. I usually recommend to my clients, since it's so expensive, that you ask the school in writing to pay for an IEE if you feel like their evaluation is not complete enough. And the school can pay or file for due process hearing to show its evaluation is appropriate. And the parent, you always have the right to file a state complaint or for a due process hearing if you feel like your child's educational rights are being violated. In most cases, with this as complex as mitochondrial disease is, the school district will be more than willing to pay for the IEE. And that has to do usually with the prognosis of the child. So under IDEA, there are areas of qualification for children with mito. Most of the children will be only qualify under one area, which is the OHI, or other health impairment. And we'll say, okay, great, they qualify under IDEA. It's important if they have any of the other criterion that they are also eligible for, that we get that on their IEP. And the reason for this is money. The number of qualifications under IDEA really drive the amount of services that children have. And I wish I could tell you that that wasn't that way, but this is really a numbers game. So they can also qualify under speech or language impairment, vision impairment, which blindness is just under vision impairment, hearing impairment, orthopedic impairment, intellectual disability, or multiple disabilities. Multiple disability criterion in most states usually leads to the most services. I always recommend that you take whatever connects you to services and then modify it as you go on. We started preschool, like I told you, we started in preschool. We started preschool with speech or language impairment and the hearing impairment, and then we went up to OHI. So these are going to be fluid, but the more services that your child needs, the more areas of qualification that we need to make sure that they get accepted under. So when I say OHI or other health impairment, what do I mean? So the other health impairment means having limited strength, vitality, or alertness, including a heightened alertness to environmental stimuli that results in limited alertness with respect to the educational environment that is due to a chronic or acute health problem, adversely affects a child's educational performance. When I hear this, I think Mito. So that limited strength and vitality, we're going to look at those fatigue. We're going to look at those child-specific symptoms. Alertness, once again, you have that fatigue for many of your kids, but this could be anything to where they're in pain and that sensory stimuli is causing them not to listen. And that environmental stimuli, how about, not being able to regulate your temperature? These are all areas that speak directly to Mito. And the whole piece that is very important here is that second one, adversely affects a child's educational performance. Everything has to go back to how they're going to perform in the classroom. So I know I used this term before, but what is FAPE? Because FAPE is the bedrock of the IEP. So FAPE is that free and appropriate public education, and it requires special education and related services that are provided at public expense. It should never cost you anything. It meets the legislative standards, includes preschool, elementary, or secondary education, and are provided in alignment with the individualized education plan or the IEP. So public expense means that you don't come out of pocket. There is one area of exception that some parents do not know about, and that is if your child is eligible for Medicaid, they can, if you sign consent, bill Medicaid and be reimbursed for certain services. That includes nursing services, that includes speech and physical therapy, occupational therapy, but that is only if you consent, and you should never be asked to take any money out of your pocket for these services. But FAPE is the essence of special education. It's going to be our touchstone throughout. So you go through the evaluation, you get your reports. You have to go to an IEP meeting to determine eligibility. So who participates in this meeting? It is a lot of people. So we're going to have the parents or the caregiver, a representative of that LEI who is authorized to make decision and commit resources of the school district. This is important. Usually this person is a principal, but if it is not someone that can commit resources, it is not legally compliant. So we're going to have a general education teacher. Even if your child spends all of their time in special ed, they're required to have a general education teacher that can speak to what is required by the state for that grade level. Your special education teacher will be present. Personnel for the school district knowledgeable about the instructional implications of the evaluation. That's usually going to be a special education specialist. This is usually someone that is employed by the school district, not the individualized school. So your experts. So you can have your occupational therapist, your physical therapist, speech, school psychologists, clinicians, any of your outside personnel, such as your speech therapist, your occupational therapist that you pay for outside of school, they can be invited and they can participate in this meeting. In order for it to be legally compliant with mitochondrial disease, your school nurse who will support your child directly every day needs to be present in this meeting. I cannot emphasize how important this is because that school nurse will write your child's IHP or their individualized health plan. We need to make sure that that nurse knows everything that we're telling them. So the child, where appropriate, and this is usually at transition age. Transition age varies by state. Here in South Carolina, it's at 14. There's other states where it's 16, and then their child is required to attend. But you are also able to have an advocate or a support person for the parent or caregiver. In each state, there are people like me who work for nonprofits who can come in and be that educational support person for you at no cost. But you are allowed, if you would like, to have a paid advocate as well. So that last person is really at your discretion, but all of these other parties are required in order to compromise a complete IEP team and for the IEP to be considered legal. So what is an IEP? An IEP is an individualized education plan under IDEA. So it must be developed within 30 calendar days following that evaluation. It must be reviewed and revised at least annually. If your child has a neurological complication from their mitochondrial disease, such as seizures, this must be revised at least quarterly. Parents can request IEP meetings at any time to address concerns with the IEP or accommodations. So this means that for any reason and no reason at all, you as the parent are free to ask for a meeting. And once again, we want to do this in writing. I usually recommend to parents that we send an email to the special education teacher and to that LEA, so that principal or whoever that person is that attends your meetings. And your plan should be updated anytime there's a significant change in the health status of the child. If you say, for example, your child had COVID, and after they have long COVID now, you know, their fatigue is going to be heightened, their tolerance for temperature has changed. We're going to address that in the IEP whenever we have any sort of change in status. So copies of the IEP, including those individualized health plans, should be given to all the school staff that works directly with the child. And this is very important because in every state, you will have to sign consent to who you allow to see the IEP. The person that transports your child, that bus driver, that bus aide, they need to see the IEP in order to know what that child's accommodations are. Some people I recommend give it to everyone. If your child is an eloper or runs away, goes outside, gets confused. I even wanted the janitor to know at that point, because we need to make sure that this child is serviced in the most appropriate way possible. So just make sure that you check that distribution of the IEP in that initial meeting. So what's in the IEP? And we're going to go over this and we're going to get into more detail here in a little bit. So special factors, your present levels of academic achievement and functional performance, or a PLAF statement, child-specific measurable annual goals, including short-term objectives or benchmarks for some students, how a student's progress will be measured and when progress will be reported to the student's parents, statement of the specific special education services, related services, supplementary aids and services, and program modifications or supports for school personnel. We need to know where the child will spend the academic day, if they will be with mainstream students in the general education environment at any period during the school day. So accommodations on testing, including state and district assessments, which could be different. Time lanes and breakdowns of service minutes, including frequency, duration, and location of services and modification. And we need to have that transition information by the age of 16 with state-specific variations. Here in my home state of South Carolina, we start transition at 14. And what all of these things they do must do is they have to answer these 4 questions, and these 4 questions are super important. Because anytime we consider what our child needs, we need to make sure that their plan is answering these 4 questions for that need. So what are the student's unique academic function needs that must be addressed in their IEP? What measurable annual goals should be included in the student's IEP to address the academic functional needs? How will the student's progress towards the measurable annual goals be measured? How do we collect the data? These are all data-driven decisions that we're going to be making. So what academic functional services will be provided to the student so that they may reach their annual goals? So if we start at the beginning of the IEP, it's always this consideration of special factors. These are literally yes or no questions. They're check boxes. So the first one is, does the student's behavior impedes the student's learning or the learning of others? If your child is prone to outbursts, this box will be checked. If the student has some functioning issues or some like ADHD, this box is usually checked. The second box would be the student exhibits behavior that requires a functional behavior assessment. This is, you'll be heard it called an FBA. Most states do not have a functional behavior assessment unless your child gets expelled more, or excuse me, suspended more than 10 times, and they go to something called a manifestation. So the student exhibits behavior that requires a behavioral intervention plan. Once again, this is more extreme behavior. The child has limited English proficiency. The student is blind or visually impaired. The student has communication needs. The student needs assistive technology devices or services. If any of these apply, they will be checked in this section, and then they'll have supporting accommodations. So then we go to placement, or least restrictive environment, or LRE, as they call it. An IDEA requires that students be educated to the maximum amount possible with their non-disabled peers. So if we look at the diagram to our left, the least restrictive environment starts at the top, and that's going to be your regular gen ed classroom. And your most restrictive environment is going to be your hospital homebound. Now, there are a lot of kids that spend some time in the hospital homebound, which is fine for short term, but we want to keep working it up to be the least restrictive as possible. And that doesn't mean that we don't sometimes need other supports, but the law does require that we continue to work towards that educational independence. But this decision must be made by the IEP team and not solely by the school district or school personnel. There's something very specific in the law. It's called pigeonholing. And pigeonholing is when you go into an IEP meeting and they've made all the decisions about where the child should be without your information. They have not considered your opinion or your thoughts on that placement. And pigeonholing is against the law. Pigeonholing happens more commonly than we know, but it is something that you need to be aware of. So school districts are prohibited from making placement decisions before that IEP meeting. If they tell you, sometimes they'll give you a draft IEP and they'll tell you, well, this is what we're going to do. That is not the case of what they are allowed to do under the law. So next, we're going to unpack these PLAF statements. We're going to identify need and PLAF or present levels of academic achievement and functional performance. So these provide that foundation for the justification of special education services. So proper PLAF statements note the student's strengths. We always start with what our kids do good at. We identify what a student needs, the impact of that need on general education, if it serves as a baseline for current levels. We connect that need to a goal, objectives, or both, and it includes parent input. An example of something that's in a PLAF statement for my child was that he was a high fall risk. So his strength when it came to his high fall risk, what he was able to identify when he was in high school, that he was going to have more issues at a given time, or he was more fatigued. So his need that we identified was when he was more fatigued, he needed individualized assistance to transfer in his case. And how did this impact the need? How did it impact general education? Well, in high school, he had to move from class to class. He couldn't do this without this assistance. That mobility issue was his baseline. So it did. So yes, it served as a baseline. And how we connected that to a goal and an objective. His goal was that he would articulate every time that he needed assistance. And his objective would be it was 5 out of 6 trials, he would articulate his need, and his need would be met by that paraprofessional. And this included my input because I was very concerned about the falling. But that's just an example. And frequent and chronic absence. And once again, it's very important to avoid interaction with DSS that we address this. So that PLF statement should include a statement about the need of the child to miss school frequently due to complications of mitochondrial disease. If this is in the statement, you are legally protected. So this statement should be reinforced by a letter written by the child's primary care physician, not the mitochondrial disease physician. We want this to be primary care. The reason that they say primary care is because they're going to see that doctor more frequently. You're going to have more frequent interaction with that doctor. Some states, you may have to sign a consent where the physician doesn't say what you were there for, but just says you had an appointment. And you want to be as specific as possible, including statements about fatigue, frequent and reoccurring infections, chronic pain, immune system dysfunctions, if they're present. So during periods of high transmission of communicable disease within the child's school may still trigger a state-specific legal action against the parents, generally after 7 to 10 absences in a semester, unless this is addressed in the IEP. I have personally seen parents be taken to court for what they consider truancy because they did not have this in their PLF statement. You also might have to complete a chronic illness form. And then you sign the top and your primary care physician will sign the bottom. With this chronic and frequent absence, you want to make sure that your child's school nurse is aware that this is in the statement. Even if they're in your meeting, it's best to contact that nurse individually and make sure that they know. In many areas, you can get a nurse's excuse if they have the statement, and then it will never go to that 7 to 10 day mark. And this is more about protecting yourself legally and protecting your child. So now that we've talked about chronic and frequent absence, let's talk about compensatory services. So compensatory services is the eligibility determined by the number of school days missed and the potential for regression in skills. So these services can be delivered in person, virtually, or a hybrid of the two. So parents should contact the special education teacher after more than 7 to 10 absences from instruction to determine the eligibility of the child. And the amount of time for these services are determined by the service minutes allocation in the IEP. During COVID, I had many clients that had that virtual service. So they had virtual reading assistants, virtual speech therapy, virtual OT while their child was out. This also, why I mentioned the 7 to 10 absences is because this also protects you as far as what we call credit recovery in high school or for that attendance need. Your child will have service minutes allocated. The service minutes can be, say, okay, 30 minutes of speech therapy twice a week for the entire school year. If your child does not receive all of that time, they can be allowed that service in the summer for compensatory services. If your child regresses, I know mine did a couple of times, we went to he didn't take as long of a summer break, and we started some of his services earlier. So these are just here as an additional support in case your child needs them or they do have that chronic and frequent absence. So what are the components of a measurable annual goal? So we have our target behavior, which is what we need to change. Our stimulus, material, or condition. How will we measure change? Criteria for acceptable progress. How will we know that the goal has been achieved? And a timeline for goals. So what is that timeline for mastery? And no, it can't be before he graduates high school. So data collection. I always say if you can measure it, you can manage it. And if we don't know how they're going to collect the data, we don't know how they're going to make decisions. So your IEP must state when and how the data will be collected. Is it something you're going to do quarterly? Is it something they're going to do monthly? It has to say. The data must be collected on all areas that have developed goals. So this can be that you need to have a mini reevaluation for physical therapy, occupational therapy, speech therapy. Are we going to go off of a standardized test or educational performance? So in the case of Mito, this may also include medical information. So what we're going to look at is fatigue. We might just be documenting how many times your child needs accommodations for fatigue. But what does your child need to have tracked during the school day to ensure their health and safety? Once again, what do we need to measure in order to make sure that this IEP is working? So your blood sugar, pulse rate, seizure activity, pain levels, blood pressure, oxygen saturation, anything that your doctor wants tracked during the day or that needs to have orders for the school nurse to track, it needs to be in here. We need to talk about how we're going to measure it. I want to take a minute to talk a little bit about this Supreme Court case. We call it Andrew. So this Andrew case basically says that the IEP must aim to enable the child to make progress. So that means whatever goals that we set for the child, they have to be able to achieve those goals or make progress towards achieving those goals. And they said that after all, the essential function of an IEP is to set up a plan for pursuing academic and functional advancement. That means that we have to have some improvement, but it has to be more than a minimum benefit to the student for an IEP to be compliant with federal law. This means that they can't not try things because they're hard or because your child struggles in this area. And this is something that you'll see a lot. And I wish it was different. I really do. But there are going to be many times where they say, okay, well, that's fine. The one area that was very frustrating for me as a parent was when they wanted to discontinue occupational therapy for handwriting because they said it doesn't matter, everybody types. They couldn't do that. So you have to be aware that they have to allow them to make progress. So whatever support it takes for your child to make that progress or to get through, your child is entitled to under this decision, which is binding. They don't have a choice, really. So if you feel like your child needs that support, that's something you should work towards. And so if an educational placement does not have a greater benefit than that minimum, your child may also be eligible for specialized private or education at public expense. And this does happen a lot. especially with complex children, at least in the southern states. It is starting to come around more often. And this can be a specialized school, or in some cases, it's more that hospital type environment. So I throw out a lot of terms, but we're going to talk for a second here about accommodation versus modification, because they are different. So an accommodation is how we're going to make changes to allow for a student to meet the same standards as their peers. And a modification is what changes to eliminate the standards that a student must meet to complete a grade level or graduate. And in most states, your child has until their 21st birthday to attempt that graduation. So accommodations and modifications for Mito. So school districts are required under ENDRU to address all of the students' needs. And this includes any and all required support services that are not legally required to be performed by a physician. So such as cochlear implants for hearing impairment or surgically implanted medical devices. So this does include all of those support therapies, that daily nursing care, and all of those things that your child may need. I keep emphasizing what your child needs, and because you are the expert when it comes to your children. If we don't consider certain areas, it's more difficult for them. We're going more to that equality than the equity that we talked about earlier. So just know that there are very few things that the school district is not required to provide during that educational day. So if we go to general, if we just look generally for accommodations and modifications, so the child-specific medical education sessions for all members of staff that may assist the child. And what these child-specific sessions are is that they'll go through and they'll talk about everything. So we'll talk about headaches, for example. We'll talk about hearing impairment. We'll talk about all those things. And it's specific training on how those things affect your child. A lot of these educators or paraprofessionals, it'll be the first time they've ever heard of mitochondrial disease. Some of them might not know how many areas it affects. This child-specific medical education really helps to make sure that we're treating the whole child. So your child should also have a robust individualized health plan, or an IHP, following all physician recommendations. In most states, these are considered standing orders. So anything that a doctor can put down that they need to have done, it goes in that IHP. And the IHP may cover certain accommodations or modifications that are not supported under IDEA. So for some students with diabetes, for example, it is not covered under IDEA, but they take the time out that they're missing class to have their sugars checked. This is covered under the IHP. And these accommodations must cover all areas of need. But we're going to cover some generalized recommendations based on symptoms of Mito in the next slides. So the first area I want to talk to you about is accommodations for communication, expressive language, and writing, because these are all kind of tied in together in most states. So one of the first that you're going to think of is speech therapy, which is important if your child's having problems with language. But it is also important if we set up speech therapy that we're addressing their communication needs at the time. So this is going to be your alternative communication method, PACS, sign language, the use of a device that speaks for the child. We need to consider both of these in tandem if a child has a communication delay or communication impairment. Adaptive technology to do those assignments, so speech to text, assistive communication devices, and these don't have to be super high tech. I have many children that have like an iPad and it has a preset, I need to use the restroom. They can hit the button and we go on from there. So alternative instruction methods such as chunking. And what chunking is it breaks down an assignment to its specific point. And it takes away all the extra information. So we also have shortening of assignments, the use of a scribe, extended time for assignments. And that time is dependent on state law. Here in South Carolina, it can be no more than 2 times the length of the assignment. So we can provide a copy of in-class notes so they don't have to do all the writing. Preferential or optimal seating. And this doesn't necessarily mean out front in front of the teacher. For some kids, it can be away from the window, away from distractions, in the back of the classroom. But this also allows for the use of visual cues and nonverbal response. For my son, when he did not feel well, he didn't want to talk about it, especially as he was older. So what he did have was a Post-it note, something simple like this. And on it, if it was a certain color, like pink, he would hold it up. His pink Post-it meant that he needed to go see the nurse. This use of nonverbal response meant that if he was having a neurological issue, he was able to leave when he needed to, because sometimes he had problems with the communication. We also use these a lot with small children. It can be a card, it can be a nap pass, it can be a I need a break pass. But these use of the nonverbal response helps to eliminate some of that frustration that will come from that inability to communicate at that time. And it can also be used to allow the teacher to know that we need to modify the assignment or they're getting frustrated. So we're going to talk about mobility and postural difficulties here for a moment. And this is more than physical therapy, and this is more than just having an access to an elevator. So what this accommodation includes is handicap accessible transportation with an aide or a health professional. There are going to be children that cannot simply just ride the bus with an aide and be okay. This handicap accessible transportation, once again, public expense, and it should require whoever they need, clinical professional, to be there. So alternative seating to allow for proper positioning. Many of our kids can't spend all day sitting upright. So this could be even like the use of a recliner. For some children, they prefer to be moved to a rocking chair for a few hours of the day. But this is all included in this accommodation. So extra time for passing between classes, sometimes we call this a preferential passing period, where instead of 5 minutes to pass, they're given 7 or 8. This is, once again, is going to be very child specific. A physical therapist determined ergonomic seating. I've had one young gentleman where he had problems getting in and out of his seat, and they put a stretchy band around the bottom so he could rest his feet and help push himself back up and into his chair. So physical therapists are okay. I talked about that. One-to-one assistant. This is going to be, some people might call him a shadow. This is someone that works specifically with your child on whatever it is that they need as far as their personal care. Adaptive physical education and recreation. This is either a specific class for that child or accommodations within that PE environment. So also adjustable height desks and tilt tables. We can use note takers, scribes, and lab assistants. Alternative keyboards. Course and program materials in electronic format, which is one of the ones that I love. If your child is required to have textbooks, then they need to have books available in the classroom and a second set of textbooks for home, so they're not carrying things back and forth. And the instructor sitting down or moving back to create a more comfortable ankle for a child for conversation and instruction. No one should have to sit in their wheelchair and look up at the teacher all the time. That instructor can make some simple modifications to take some of that pressure off of that child to constantly have to look up at that instructor. So pain. Pain is a difficult one. So IHP medication plan should include medication distribution schedule if applicable. Some kids will need, different narcotics or other drugs during the day to help them with pain. If your child needs drugs like over-the-counter drugs like ibuprofen or Tylenol, it needs to still be in this plan that they're allowed to dispense it, and you need to have written consent from your physician for a child under a certain age, and that varies by state. So we need to identify and adapt for any pain triggers. Some of our older children that don't have as many mobility issues, because still if you have pain triggers from having to climb stairs. So even though they don't necessarily have a mobility issue, they're still eligible for an accommodation to use the elevator, for example. So we can also waive that physical education. Each state requires that in high school, a child receive at least 1 credit for gym class. This can be totally waived due to pain. So a gradual return to school after periods of illness or high pain. I call this a fade. So you have a 6-hour school day. It might be after a period of high pain, we go back for half a day. Or sometimes we can go back 2 hours and then we ease into that full day. So short breaks for pain control rather than being sent home. This is important because sometimes with a lot of kids and working in the schools myself in that health capacity, we'll feel better after a 30-minute break, some ibuprofen and some water. So we want to set those breaks aside and plan for them in the IEP rather than every time your child says, I hurt, my head hurts, my leg hurts, I want to go home, that they're not just quick to bounce them back to you. And then once again, that second set of textbooks in the classroom. So no carrying of materials from class to class. A lot of people right now, it's the Chromebook that they use instead of textbooks. And sometimes they can have a peer buddy carry that for them. But we also might have to look at modified day. And modified day looks different in each example. But in one example, we didn't do mornings, we did afternoons. And then they received compensatory services all summer in order for the child to still pass on from grade to grade. But in the morning, the child didn't feel good, had a tendency to have higher pain. And it's totally and completely acceptable to modify the day if we need it. And we can also use that homebound instruction during higher than usual pain periods. And homebound instruction means that someone will either come to your house or it will be virtual, but your child will still receive the same instruction that they would during the school day. And that includes those supportive services like OT or speech. So let's talk about fatigue. There are many ways that we can accommodate fatigue, even though as a parent, it seems like it's the most prevalent thing in your life sometimes. So this can include a lot of things. Permission to sleep during class. As long as your child isn't disrupting others, there's no problem with that. A nap pass for the nurse's office. Once again, as I told you, it's that little pink post-it, I have to go. And then you can set a time allotment for your child. Say, I don't want to be contacted unless he's sleeping longer than 60 minutes. If she is sleeping, 30 minutes, It's no big deal. So we can also schedule nap breaks in. Instead of study hall, sometimes let them just sleep during that hour and 15 minutes. Snack breaks seem to help. So sometimes they just need that extra little boost of nutrition, a little boost of sugar, so they can take that time out. Once again, we can go with a shortened or abbreviated school day. We can excuse from or modify that physical education. We have a lot of the same note takers, scribes, and lab assistants. And the modified schedule for many of the kids can be like, you can work on their frustration tolerance for physical activity, say. So say your gen ed 4th grade is at gym class. Your child may participate for 10 minutes and then sleep for the next 20. Go take a nap in the nurse's office. But there's this concept, the next concept I think is very important. It's modified or reduced assignments and extended time, but we want to focus on mastery over completion. What mastery over completion is if we're learning our times tables. Instead of you answering 20 questions, I'm going to cut it down to 5. And it's going to be the 5 that you really need to know. Or in social studies, we can cut down the chapter and then we can just focus on bit by bit what you need to learn. And virtual instruction is also a great option here. A lot of states are going, since COVID, more to that virtual instruction or that credit recovery. So if your child has more fatigue and misses more school, they can go to a virtual academy and complete that school year. So that might also be an option here for fatigue. So physiological responses are symptoms that occur as a result of stress, either physical or emotional. So these accommodations are based around building in predictability to the school day and decreasing the possible side effects to memory, cognition, and learning. So it's going to be things like preferential seating, extra time and warnings in between transitions. Sometimes this is use of a visual schedule, which will tell them when things are going to happen. Sometimes it's a setting an alarm. Sometimes it's a verbal prompt, but lets them know 10 minutes before we're going to transition to this. So if you can start wrapping up. So clearly stated and written expectations are important for a lot of kids. And this can be, sometimes I've seen it in the Google Classroom where they write a note, this is what we're going to do. And then it's reinforced verbally by the teacher. But this is also frequent check-ins, like how are you doing? Do you need any help? Not badgering a child or making them prompt dependent, but just checking in periodically through the day, usually about the same time. But a peer buddy, especially for a younger child, this is a powerful tool. And this is a peer that's in their classroom that can help them with certain things, or if they don't know where to go, like what page are we on, or what screen should I be on? They can ask their peer buddy for assistance. But we also want to fade into changes. So we're going to temporarily increase or decrease services. So say your child's been out sick for an extended period of time. When they go back to school, we're not going to pick up immediately with all their therapies. Like they can spend more time in the classroom and they're not going to speech or whatever is your preferred fade. Sometimes after a period of prolonged illness, we may have a one-to-one aid at that time, and then we gradually phase out that aid. So we can add or we can subtract at that point. But we also can have an adaptive schedule after periods of illness or absence. And that can be that modified day. That can be the inclusion of homebound. It really just depends on that individual situation. So medication and nurse provided services. Every school should have a nurse that your child attends. if your school does not have a nurse, this is something that you can ask for the district to fund at state expense, at public expense once again. So this could be scheduled nursing services, such as your medication distribution or your vital recording. It's going to be personalized one-to-one nursing during the school day. Substitute nurse planning is very important. That's why it's important that that nurse is part of your IEP, so that we can make sure that she knows or he knows everything that we do during the day. And this also is going to include some related services that we're going to talk about on the next slide. But this is why, like we talked about in evaluation, that we consider that whole medical day. Because if something happens, like I live in hurricane country, if your child would have to stay at school, would that nurse be able to provide care for the entire day? So that's why we need to make sure that all of these things are in place. But when I talk about related services are those that are required to assist the child with a disability to benefit from special education. So all these services below: audiology, mental health counseling, OT, orientation and mobility services, physical therapy, psychological services, recreation, including therapeutic, rehabilitation counseling, school-based nursing services, social work services, and transportation. These are related services because these are reasonable accommodations for someone to be successful. So sometimes with some of our older kids, even like, so if we talk about like mental health counseling, it can be, you know, understanding your illness. It can be, you know, talking about your frustration with how things are going health-wise. It can also include therapy for the parent if the parent needs that additional support. Of course, we at the UMDF, we are always here for you, but sometimes you need that immediate support at school. This is something you can get as a related service. So accommodations for hearing impairments are going to be a lot of the same things. So we're going to look at preferential seating, pre-teaching new concepts. I really like this method. I think it's very powerful, where they cover the material more than once. Most states have a standard where they're required to introduce 2 new concepts a day. As an adult, to me, it's overwhelming to think about learning that much, considering most of these concepts 6 or 7 classes. So if we start with, if we pre-teach, we roll them into these concepts earlier, like taking time or telling what time it is. We're going to start that child off a little sooner so they get a little bump in advance to when they have to be tested or know these concepts more concretely. So student-specific prompts before beginning the lesson. I've even had some teachers hold up like a pin or even a popsicle stick with a sticker on it, or different things that that child knew to look for to let them know that we're going to start the lesson. We're going to reduce the background noise, which is harder than you'd think as someone that's spent a lot of time in different classrooms. And we're going to provide interpreting if they need it, and rephrase and repeat information. And we're also the use of adaptive technology. Most schools also have like it's a little battery pack that they link up to the teacher and they can speak into. The child wears a device that allows them to hear them. But that check-in for understanding and frequent check-ins, those are powerful tools, because then the child feels heard and they feel like their condition is being taken seriously. But that preferential seating, I also want to make sure that you have it in there, that they can see the face of the instructor. Because a lot of these classrooms now, with Promethean boards and other technology in there, they still need to see that person's face in order to ensure that they're hearing properly. So if your child has a vision impairment, we're going to once again make changes in instruction. So large print, braille, or an oral administration of tests. Modified assignments. But this bold line paper, these are some newer things that some people are using that I find have really great results. So it's darker. So if they're just starting to lose their vision, it makes things look more dynamic and sharp to them. So seating away from windows is one that I put in a lot of IEPs when I have children with visual impairment, because research has shown that the glare from the natural sunlight mixed with that fluorescent lighting that's in these classrooms can actually impair the vision further. So consistency in where materials are placed is also important. If they're going to change the classroom, they need to let their child know that the classroom is going to be changed. So the use of magnification devices, extra time for assignments with double time for written response, I'm going to say no more, less than double time ever. Double time does not put an undue burden on the teacher. So it lets them have that time to get all of the written material done. So manipulatives to learn new concepts. This can be anything like we use spaghetti models is what they call them, little clay figures to do with bumps, to do addition and subtraction, for example. So once again, that scribe or that speech to text. And some people need more lighting. So we're going to bring in lighting as we need to, or take out lighting as we need to. This is really, like I said, individual based. So I know I talked about a whole lot here. So these are some important things to remember. You are the expert when it comes to your child's needs. Let me tell you, I've done this a long time. I've been in a lot of IEP meetings, and I don't want anyone to ever tell you that you are not the expert. You are the experts. It doesn't matter who's in that room. You can have the smartest people in the world. No one knows your child like you do. So when you go into these meetings that can be highly adversarial, you need to remember that. You have the right to participate in all parts of the educational planning, including evaluations and observations. If they say, oh, well, he might do that at home, but he doesn't do that here, you have the right to go in and observe. Sometimes they're just not looking at the right time of the day. Sometimes they may be misinterpreting something that you're saying. So you have that full right of participation. You are afforded that under the law. So parents and caregivers can invite anyone they choose to attend their child's meetings, including clinicians and advocates, both paid and unpaid. There are lots of people that say, I don't want to hire an advocate because I'm afraid they're going to take it out on my child. And they might have a little bit of attitude about it at first, but usually the parents that have advocates tend to have better outcomes for their children. I always say that when I go in, they know that I know, and I know that they know that I know. So they know that the advocate knows the law. They know that advocate knows exactly what's allowed and what's not allowed. And so things generally flow smoother. And those clinicians can be a very important piece, especially if your child's highly medically complex. If you do not agree, you can file a complaint, you can file for due process, mediation, or facilitation. A facilitated meeting is usually someone that works for the state Department of Education that comes in and really drives a conversation. But remember, educational planning meetings will be emotional, and it's okay to show that emotion. If you cry, so what? You cry because you care. And it's super important that you sometimes you show them your vulnerability so they understand how important this is and what, you know, that you're invested in the process, that you're part of the team. And once again, you are the expert, so try not to feel intimidated even when the team is large. You're going to have some periods like during evaluation, you could be in the room with upwards of 15, 16 people. But just remember, you are that expert. They are experts in their field, but you are experts in your child. And ask for support when you need it. So this can include advocates, that can include any of us at the UMDF, family members, friends, whoever you need with you to get through the meeting, take them. Schedule someone to come with you. And I also have a few books that I would recommend reading. So Developing Educationally Meaningful and Legally Sound IEPs. It's a good book. It is a little bit more technical, but this is more if you have specific instances where you know that you're going to have some problems or you've had problems in the past. And then From Emotions to Advocacy, which is a special education survival guide, and it's by Peter and Pam Wright. And you can get either of these books on Amazon. And if you do I think it's called the Shop for a Cause and shop with the UMDF, we do get a portion of those sales back as a donation. But if you have any questions, please reach out to us. And I hope this was very helpful. And just know that I've been there. My son, we did an IEP review every 30 days from the time he was 3 to the time he was 19. So I have been in the room on both sides of the table, and I know that you will get through it. So thank you for your time.